And okay, so I started recording now. So when I used to practice in Egypt, I way back when I started practicing in Egypt, and that's like a good like what 13 years ago, self-harm and cutting was not very big because social media was not very big as well. So the culture itself of cutting was not common. What I used to see was self-harming with other ways, like you said. For example, the biggest one that we used to deal with in terms of risk was promiscuity, was young girls who are putting themselves in sexual harm, and the intention was always quite clear when we assess that behavior. It's always quite clear. It's always about I feel X and I need to either release or self-punish. So it's kind of a bit of a very clear kind of self-harm cognition, paralleled to substance use a little bit, paralleled to cutting when I came here, which is very big in the Western culture. Cutting is very big. And then recently we're seeing more burning and aerosols and things like that. So the definition of so when we're thinking about self-harm, are we thinking about we're thinking about so many behaviors. What other behaviors do you think are are in that sense? Like I've seen that, for example, in Saudi, and I lived for a bit in Saudi Arabia, and cupping, interestingly enough, was one of the things that people would do with that intention, is that I feel like I'm really stressed and I need the release and I need to feel that pressure, like almost like bloodletting kind of thing. And it got me thinking about bloodletting actually, because that's quite an ancient acceptable behavior. And when you call it bloodletting, it sounds quite harmless. And then when you call it cutting, it feels a bit more weird. And I suppose the reason why, sorry, go on, Catherine, you were going to say.
No, I was just about to say that's a really interesting take. I would never have, I don't think I'd have put those thoughts together, but that is, I mean, that was therapeutic bloodletting, wasn't it? That was part of healing, it was part of treatment, and it made sense in the those much older ways of conceptualizing health. But when you call it cutting, it sounds completely different. But actually, and I don't know, I think a lot about the senses. I think my autism role makes me think about senses, and I think about interoception a lot, and the predictability of creating something that painful that your brain can make sense of to give you that interoceptive feedback that you might struggle with, especially with neurodivergent people. And I think you cut yourself, your body feels a certain way, your brain can understand what that means, and that's quite grounding to get that interoceptive feedback in place where it's otherwise potentially lacking. So I think about cutting and even tying we have obviously on an inpatient ward, we get a lot of time with very tight ligatures around necks as well.
Mm.
And I was reading about interoceptive ligaturing as a concept to create a feedback process in your body that makes sense, that gives you that sense of being, that presents that being grounded that you don't often get because you're not usually in tune with what your internal processes are. So I was just thinking about cutting and how it could be seen as a thing for good or a thing for harm. It's very interesting.
I found, you know what? I found the exact same thing when sometimes my patient, and this surprised me. I had a patient who said something to me about control. The main pathology for her was about control. The only thing I can own and hurt and deprive or give or feel was my body. When I
Exactly. Exactly that. We've because we obviously have very strict conditions, so the opportunity to self-harm is
Mhm.
limited. And usually the final thing is what they put into their body. So eating and drinking, and they will restrict because and they'll say this is the only thing I have any sense of control over, the only thing I have left. And that pursuit of control, pursuit of autonomy and agency in your own life. When you're deprived of that, you'll seek it in ways that seem so unhealthy, but actually it does make sense. If you feel like you have no control, you find it wherever you can, even if it's unhealthy, even if it causes downstream problems.
That's very interesting. And I think it's one of the things now you've said about inpatient and one of the things that we often are seeing now, increasingly over the past few years, was inserting objects into your body. And it used to be so weird. It used to be so alarming that you'd call up and say, "Oh, I've got a patient who inserts things in under their skin," and they go like, "Oh yeah, we have to admit that patient." And now it's becoming more and more
Mhm.
common.
Yeah.
Mm, and it's always, when I've discussed it with patients, always went in my head, it went so along with eating disorder cognitions and the pathology behind control in eating disorders. So you control
Hmm.
what goes in and what comes out, but in a very graphic way.
Yeah.
I think, and I'm wondering, we've got colleagues here who are just joining into the conversation, and we're talking, so we catch you up. We're talking a little bit about self-harm, where it comes from, and when is it normal and when is it not normal. But I'm thinking about, does it matter to people if we normalize self-harm? Because I used to have a patient, a parent who would take lots of was very worried about this idea of normalizing self-harm, of going like, okay, it's okay to self-harm. Listen, it's okay. We've got this self-harm kit and we know what to do if that happens. We're going to try to replace it bit by bit. But step one is just try and take the noise off a little bit. So it doesn't provoke a lot of emotion. And I'm wondering how people find the interaction with parents around self-harm and having those discussions about, oh, self-harm is acceptable in some cultures. It used to be actually acceptable in the Western culture as a form of, you know, treatment when you call it bloodletting and when you call it like extreme muscle man massages and things like that. It sounds quite nice. But so how do you, when you have discussions about self-harm with parents, is anything coming up that's interesting?
I suppose not normalizing self-harm per se, but normalizing the need for an outlet.
Mm,
Um, Depending on the context of why we self-harm, but working with teenagers, um, and now working in a tier four GAU myself, that sometimes is one of the ways to connect with that young person.
mm,
Because similar to your vignette, when the mom is punishing Sarah for self-harming, that will probably just make it worse. It's not just about telling them off and punishing them or whatever. It's about normalizing the need for an outlet and understanding the purpose that it is serving them a purpose. They're not just doing it for the sake of it. And then when we start looking for alternatives, I think that's one of the ways of going about it, is that we understand why we're doing it, or we're going to try and understand why it's happening, and then we try and offer an alternative. Because if we don't offer it or think of an alternative, then we didn't do anything. If anything, we might have taken away their way of coping
mm.
altogether, which might leave them worse than before.
I think you're absolutely right. And I think it's about, like you said, normalizing the need for an outlet. And thinking about the tree analogy, um, which is not perfect, but I found it helps me a little bit when I'm doing a formulation, because I'm thinking about the developmental kind of roots, foundations, not just how this child is built or how this young person is built, not just their core beliefs about themselves. I deserve pain, or I emotionally dysregulated, or I self-harm, which is very, sometimes we see that things kind of are so enmeshed in the identity. The pathological behavior is so enmeshed in the identity that it's just, I am broken, I am beyond um, doing better, I'm beyond treatment, I'm beyond fixing. But also there are the stories that families tell about themselves. And I think we were talking about, like you said, Catherine, it's so interesting when you look at things in two different ways. Like if you put two and two together, we all come from very similar experiences of personal need for release of stress. And often I say this to my patients, like, it's absolutely normal for people to feel that they are very overwhelmed and they need a release. So after my clinic, I'm going to feel very, very, very overwhelmed and I'm going to need a release. And what am I going to do? So I have two options. I can go and smoke a weed after my clinic, or I can go and drink a bottle of wine, or I can go and cut, or I can go and pray, or I can go and wash my face, or I can go for a walk, or I can go fight with my friend. So there are so many ways that I'm going to need a release because it's been overwhelming and it's long and you need to do things. And then my choice is dependent on so many things. It's dependent on so many things, not just how I'm built. It's also dependent on my story, where I come from. So there are families that come from self-medicating with certain things. There are families that self-medicate and release through a lot of things. Some of these things can be helpful, like families that exercise or families that, do things that are quite healthy. And there are families that self-harm, not necessarily, and it's so and I keep thinking, I don't think I've ever had a situation where the child was self-harming and the family had a healthy way of coping. Like it's very difficult because I think families have their own stories. And I wonder if, because it's a very touchy topic to talk about in clinic, particularly when you have someone who's self-harming. If you ask, how does the family deal with the stress? How do you deal with the loss of a job or loss of income or a loss of a loved one? How do you deal as a family? I wonder, what do people think about that? And what do people think about assessing the family stories as well in the context of that? And I'm looking particularly at our colleagues who've just joined. Hi, guys. And wondering if you have any thoughts about families and self-harm, families who come to clinic often quite distraught, quite stressed, and worried about what's going to happen. And we need to build a picture of that child, of where they come from, of what's their own roots, their own foundation, and then what's the soil, what's happening around them, the trauma in the family, the heritage. And I'm wondering particularly about families who have come through generational trauma or generational displacement, which I imagine in the South you'd see a lot of, the south of England, that is. And I imagine if we've got colleagues who are practicing in Egypt, you'll be seeing a lot of displaced families as well. Because that's something to think about. And I think the third part is obviously the thing that we're all really in tuned in when people come into clinic is, do you have a mental illness, yes or no? And is this treatable? And then there's obviously, I like to think about the developmental stage, the branches, and because that's ever changing and it's always changing. And then you've got the leaves that are sometimes going to be healthy, sometimes they're not going to be healthy. And how are you going to deal with those leaves? It's not always the right thing to completely, discount them as an illness. Sometimes it could be part of the developmental stage. That's, I think, that takes me quite neatly into the 4Fs. Now, like you all said, when we're doing an assessment, we're not just thinking about you've got the basic risk assessment, and we've got lots of rating scales and lots of things, and they're mostly thinking about, okay, what is your mental state now? Do you feel suicidal now? Do you feel like you're going to self-harm now? Has this happened in the past, yes or no? And based on these two inputs, you try to calculate the possibility, is this person likely to self-harm again? In our experience with children and young people, predictability is not that high in terms of self-harming behavior, because it's contingent on so many things. But your best bet is to get a collaborative understanding. So this is why when I do the 4Fs, I like to do it with the young person. And I like to sit down and think with them and say, okay, look, There's absolutely, let's just not freak out about self-harming for a minute. Let's just try and understand it. What is your body trying to tell you? Your body is trying to tell you something. It's telling you to hurt it in this way, or it's telling you to inflict this kind of, experience on it. Why? Why is it trying to tell you that? What is happening? And we kind of go in a little bit of a mystery mission, and we try to do an understanding of function. And my best friend in these situations, and I'm sure for all of you it's the same, is post-it notes and markers, because then you can draw a little graphic picture of, okay, you've got the incident, and you do an antecedent, behavior, and then consequence kind of lineage. Is everybody familiar with the ABC model, with the antecedent, behavior, and then consequence kind of behavioral analysis, a functional analysis?
Yep. Yep. Use that a lot.
Do you use it in that context as well, in the context of self-harming and emotional
Yeah,
regulation?
yeah. Regularly, we encourage the young people to self-reflect and do their own. They're supported to go through with their own ABC or chain analysis and that sort of approach to understand and reflect on not just on their emotional state as well as triggers that were going on and so forth. Yeah.
So I think it's I think it's quite hard to explain to kids. How do you explain it to kids, Catherine? How do you, give us your top tip on how do you?
Well, I have the benefit of working with as just part of a really robust MDT. So we have so often our psychologists who are leading the DBT side of the work, which this fits in really nicely with, will often take the lead on that. So I'm not going to claim any sort of specific knowledge. Often I will recommend that because of this pattern of self-harming, I'll say this is a great opportunity for us to understand and to understand them to understand, and so we can share an understanding of what's happened, and then we can co-create a plan to move forward. And then I will receive the chain analysis or the ABC, and then we will reflect on it together. So I have no top tips for you, I'm afraid. But it is part of our program. It's part of our DBT informed way of working as a unit as well. So all the young people get an opportunity to sort of develop these skills. So I think it's quite scary to start with, but they realize that whatever they create when doing an ABC is going to be useful. It doesn't have to be perfect. It's not about right and wrong. It's about that journey. So just sort of helping them recognize that whatever they do, that's brilliant.
Do you find it, I mean, in contrast with outpatient work, which I think England has the most wealth of inpatient units for children, young people compared to the rest of the world. By the way, I've worked in places where like there's only one like 3-bed kind of service. So in the entire country. So I'm wondering in the outpatient world, in contrast with inpatient, you've got the containment, you've got like we have a difficult discussion about formulation, and then you can go when there is support. How do people find it when you're doing formulation of high risk behavior in the community, in your clinics? Do you have any experiences you want to have a chat about? Or so I used to work in inpatient for a very long time, and then I moved to outpatient, and I always was very scared. I always thought that, oh, outpatient is going to be really tricky for dealing with these high risk children. And I'm thinking not just about self-harm, I'm thinking about all of the other high risk behaviors, going missing, kind of high risk sexual behaviors, high risk substance misuse behaviors, criminal kind of risks as well. All of the behaviors that this child would do with the intention. And I think if we try and mesh together our discussion and our thoughts about what is the definition of self-harm and the ABC gives us insight a little bit, the antecedent, what happens to lead to the behavior, gives us insight about why the intention, where is this coming from? And then you can make sense of this behavior. Is this self-harming behavior? Is this defiant behavior? So is it just this being done to communicate something? Is just this being done to provoke a reaction? Is this being done to elicit care, to get the caring behavior? Or is this being done with the intention of harming myself? Or is this being done to deal with sensory needs? So, for example, I'm thinking like about children who have intellectual disabilities or certain syndromes where self-harm really serves a very basic physical need, a very basic sensory need, where the child is burning or cutting to achieve a very basic sensory introspective kind of need. And then I'm thinking about the more complex behaviors. So I think the function here serves the best thing, because then when you move on to the management bit, then you're thinking, okay, how am I going to address the antecedents, the things that led to the behavior? And then how am I going to address the behavior itself? And then how am I going to address the consequence? So for example, if we think about Sarah's 14, the first thing that happens is that she gets triggered by something. She is bullied. She is bullied at school, for example, and then she has ASD, so she has sensory needs, and things become really, really heightened for her. So she decides to find the sharpener blades and she cuts, but then she tries to cut on her forearms, and then at different times she'll cut on her thighs. And I'm thinking about, this is a mishmash of a few of patients that I've worked with, and you've got these two very distinct behaviors: a very obvious forearm cut, which comes with the intention of eliciting care. And then there is the more secretive cut where I don't want mom to find out because there will be a consequence to this. And these very similar behavior, they're all cutting and they're all using the same instrument, but the intention behind each is different. And therefore, the way that you're going to manage these behaviors is always going to be different. So the way that you're going to manage the eliciting care behavior is going to be different. And the way that you're going to manage the actual kind of letting or the actual kind of release seeking behavior is going to be different. And it's about the intention, about the experience, and about what happens through and after. And the second part here is about assessing the family system, is about thinking about mum, about who's at home. What is this behavior activating in the parent? Often parents report things like feeling guilt or feeling like they're acting like me when I was younger and I'm scared for them, or they're acting like brats. I can't control them. They're horrible. Or they're acting, or they're going to die. Every time the child cuts, they're thinking, oh my God, they're going to die. They're going to get blood poisoning. They're going to die. And they're thinking to the worst outcome. And parents are people too, who have jobs and who have relationships and who have their own mental health needs. And then you've got a child who you're supposed to care for, and already life is quite intense with school or exams or whatever. And then there is this. And for most parents in the conversation, it gets missed a little bit. Tell me, Catherine, what are you thinking?
I was just thinking something that crops up in my mind quite a lot is when you have a neurodivergent young person, there's a good chance that there's a neurodivergent parent who might not know that they are. And so a lot of the expression of emotions or understanding their own emotions, if an alexithymia or if there's a communication difference or any aspect or their own sensory experience and sense making of what's going on. Yeah, I just always try and mention that to people because I think we think about the young person and the risks and the role of the parents, but if one of the parents or both is neurodivergent, that adds an important dimension, especially if they don't know that they're neurodivergent because they've not had the opportunity to explore their own neurotype. As that might be brand new information to them as well.
And it's very tricky, especially when you're trying to have the conversation about containment. It's very tricky. It's very tricky for a parent who is neurodivergent themselves to contain the dysregulation, and it's often tricky for professionals. So imagine living in the house and trying to contain the dysregulation when you yourself are struggling with these similar difficulties. Absolutely. It could be a quite tricky conversation as well when you're trying to bring that to the forefront.
So, I mean, I have the benefit, I'm autistic myself and I'm ADHD, and I'm quite open about it. And that
Mhm.
really, really helps open a channel of communication with parents about their young autistic child, and then sort of reflecting on, you could be different types of people being autistic, because here I am in a professional situation where I'm very appropriately skilled and capable of doing the job, but I also have my own sensory and processing differences that I have to accommodate. And when you start talking openly about that, then you can open this channel of communication that
Mhm.
allows an honesty to take place without shame, and it reduces that guilt as well. So
Mhm.
that's something that I just find is really, from my own personal practice, that feels really useful
Mhm.
when appropriate, of course. I
Mhm.
don't just tell everybody everything at the first, but sometimes
No.
it just becomes a useful dimension.
No, and I think people appreciate that, you know. I think when at the beginning of my training, I used to be very obsessed with the I have to be a blank slate to people so they don't see personality and they can reflect. And it's a very Freudian notion of you have to be a blank slate to reflect nothing. And then it developed and it kind of became professionalism. We have to all be the same person, dress the same, appear the same, deal the same. But we're not dealing with livers and kidneys. We're dealing with people. So with complex personalities, with complex needs. And I think it's always helpful
Exactly.
for.
Authenticity, I think, is the key to it. Being authentic. It doesn't mean you have to share everything, but it doesn't mean you have to deny something that's very real and important in that moment.
And the lived experience. I think it brings an edge as well too as a clinician when you've got the lived experience of that. And I often wonder about, cardiologists, and cardiologists are quite open about, their illnesses with their patients, or, and I think especially with neurodivergence, but this is the rant for another day, is about neurodivergence being treated as some kind of oddity when it really is just people are different, aren't they? And I think it's really important to have that discussion with parents.
Exactly that. Yeah. Yeah.
But then this takes us to the big questions to ask. If there is nothing to take away from this discussion about the four Fs, I think it's important to have a think about the little thingamajig here, that little cloud. And I want to I'm going to say this, and I'm going to plant it in the back of your head. Sometimes when self-harm behaviors reduce, suicide risk can increase. So I'm going to put that somewhere in the background, because self-harm, and I often say this to patients straight up, is that self-harm can be, depending on the formulation. This is why formulation is part and parcel of the risk assessment. Sometimes when self-harm serves a certain purpose and you reduce the self-harm behavior by, for example, removing sharps, restricting the young person, or having contracts. And this is why contracts never work, or at least in my experience, sometimes they do in the context of certain therapeutic interventions, but sometimes the suicide risk can go up. And we have these discussions about, it's very similar to people in abstinence from substance, from people who are trying to quit alcohol or trying to quit substance. And you tell them initially when you're trying to stop that you might have an increase in other risks because you haven't filled the need. So the best way to do it is to replace self-harm with something immediately. But that really, in real life, it doesn't really happen. So you keep an eye and you tell the family, look, suicidal risk might increase while we're trying to manage the self-harm behavior. Very similar to when you give antidepressants. It's going to get little bit dark before it gets lighter over time. And the other thing is about normalizing emotional dysregulation. And I think this is why we see less self-harm behavior when school's out. Because I like over the summer, like I'm dreading September, because September we're gonna have a little bit of an avalanche, because emotional dysregulation is not normal in standard education. You're not allowed to be a person who gets angry at school, apparently, not anymore. So you get all of this bottled up. and then you go to the bathroom and you self-harm, or you go home and you self-harm, and then people put more restriction around you, and everybody's like hanging on your every move. Oh, you look upset. Oh, you look suicidal. Are you feeling well? Do you want to kill yourself? And that question is so incessant that emotional dysregulation that is actually quite normal at this developmental stage as a child who's growing into their 20s, and then as a person who is built in a certain way, as a person who we label as autistic, or we label as ADHD, or we label as anything that is not the perceived neuronormal. You're telling them that you're broken, you have emotions. Why do you have emotions? And I think that's really important to normalize, is that it's okay to go off the handle a little bit. It's okay, especially if you're Middle Eastern. So if you're if you go off the handle and you're Middle Eastern, that's absolutely normal. So this is the cultural thing I was talking about, earlier, is that, if you're in Egypt and you flip a little bit, you go off the handle a little bit, that's absolutely okay. Nobody says you're crazy. But then obviously here you have to really put these extra layers of emotional management, because culturally there is norm that we have to meet. And if we try to bend over too much beyond how we're built to meet the norm, then stress happens, and it's quite strong. I feel it sometimes. So let's move on to the management bit, which is Ed. We're going to think about Ed, and we're going to make a little bit of a plan for Ed here. Okay, so are you ready? Now, Ed is 17, and self-harms by burning his skin with sprays and aerosols. He cuts with razor blades on his stomach and thighs. He reports a history of generalized anxiety and panic attacks occurring every week, especially around exams and assignment deadlines. He has fleeting suicidal thoughts with no plan nor intent, often triggered by feeling stuck and negative self-talk. Example, I'm a failure. I'll never be accepted in a good university. My brother is better than me. He often self-harms more than when he has suicidal thoughts. He also secretly drinks when he is in a triggered state. These difficulties started 2 years ago. No one knows about this in his family. They believe he is seeking help for pre-exam anxiety. He has a supportive older brother who is 35, the one that he compares himself to, and that brother lives with his own family in a different property. Ed lives with his parents, who both work full-time, and he attends sixth form. So that's kind of like fancy talk for year 11. So end of his school years for people who don't live or work in the UK. This is the end of his school years and getting prepared for university. Now, your task is to try a risk management plan. And we're going to try to start with an ABC. Now, if somebody feels talkative, please do take the stage and let's try and think about an ABC here. And then we can try and address the ABCs for Ed. And if you don't feel talkative, you can put it in the chat, or you can sing it, dance it. Or you can write it down for yourself as well for fun. So let's start with the antecedent. So in here, what have we found out is triggering for Ed? What is the trigger for Ed's self-harm? And also there's a little kind of Easter egg that I've hidden here, thinking about what is self-harm. Like Mustafa was saying, what's the definition of self-harm? Is it just the cutting, or is there other behavior here that we can consider self-harming?
I think one antecedent is really around the school. It's around those deadlines. It's around exams and pressures, and he's at that really crucial stage in his education. So much pressure's put on to these young people at this very specific moment, and so I think that's a really huge one. That's the here and now that he's living in, antecedent.
Okay, so I'm gonna take notes. So antecedent, we said school pressures.
Yep.
Okay, so he feels pressured with assignments and things.
And then there's the family pressure, or perceived family pressure.
So points of comparison with his brother, for example.
Mhm.
Anything else, or shall we think about the behavior itself?
I'm aware that I find it really hard to sit in silence in these things, so I do get very talkative. When I'm in psychotherapist mode, I can sit for a full therapeutic hour in absolute silence if needed. But in these, I find it unbearable. So tell me to shut up if I'm over contributing and
Oh
not giving enough.
no, absolutely. I think it's quite different for everyone. So I think some people prefer to kind of pop their headphones on and get on with their life while they're doing two things at the same time. And I sometimes do that. And sometimes people just want to listen, and some people just
Mhm.
feel more, they benefit more when they interact. I'm definitely the talkative type, but it depends on the day. Sometimes I just want to put the thing, my ear things in
Yeah.
and just do my washing up while I'm listening to someone say
Yeah.
something really clever.
I'm on quite strong painkillers at the moment as well, so I'm feeling a little bit
Oh,
less
bless
inhibited than
you.
usual. So,
Oh, bless you. Well, that is very hardworking and like determined of you to do this when you're ill, I
I'm
think.
on sick leave. I'm not supposed to be working, but I do love a good webinar. So
Oh. Reminiscent of COVID, these webinars
yes.
just remind me of COVID. Okay, so let's think about the behavior. So we're thinking about the cutting. Do we think that
Mhm.
alcohol use is a self-harming behavior that we can think of?
Self-medicating rather than self-harming, to my mind,
Ah, okay.
which I think is a different thing, possibly to the same goal, same end point, but I think it's a different thing.
Do you think it has to do with intention?
When there's a culture, I think at his age, I'm going to make assumptions. There's probably a more societally acceptable drinking, sort of culture around them. So it's a way of him that self-harm, self-medicating, but without it being called out as a quite such a pathological behavior
Yeah,
because his mates are probably doing it.
yeah. I always like to ask to try and differentiate here. To what point do you drink?
Hmm.
What drink serves as a function? And to what point? So are you getting drunk to the point that you are not safe coming back home, or you're passing out? And in these situations, are you making sure that you're drinking with good company, with people that will look after you if you need a ride home? Or are you you're just putting yourself in harm's way? You're going into the city center on a Friday evening and getting completely drunk in a corner with no one around to take you home, or with friends that would just abandon you. Um,
Or alone in your room at home or something.
exactly.
Away, isolated. That's a very different message as well, isn't it?
Exactly. Because then I think drink is a slippery slope, particularly for this age group, and particularly when you've got this kind of pattern of self-depreciating
Mm.
cognitive process developing. And you can then quickly fall into a pattern of abuse. And this is why I like to kind of ask a little bit more about, okay, what does drink do for you? And I try to, I mean, obviously this is doctor talk, but I always say, drink happy, never drink sad. If you're drinking sad, then there's a problem. Um,
Hmm.
but this is why I thought to put this in here, because it's quite normal in the West, for example. In the Middle East, for example, and we've got some people who are practicing in the Middle East, I think, on this call. So it depends on the culture, and there's a lot of difference in what people will drink as well. So are you drinking? So some people will drink proper alcohol store bought, and some people will drink, crap that came from Bulgaria or something. So you're thinking about, what are you drinking? Why are you drinking? What situations are you being in? Like Ed is a boy who's 17, but if you're thinking about a girl, um, you're becoming quite vulnerable when you're drunk as well. Do you have the support system around you? And I think about this when you're risk management. So, okay, if you're going to get drunk, make sure you go with a good friend. Make sure that they know where you live. Make sure that you've got your phone on you, for example. And make sure that you've got your drink in your hand. No one else handles your drink. Things like this. So anyway, so let's think about the consequence. So we've not known a lot about Ed's consequence here, but I'm assuming What are we assuming about what happens after he does all of that? People lay off him a little bit, maybe? I don't know. Gets a bit of release. I suppose we'll have to ask Ed. Any thoughts about that?
I'm wondering how he feels after the drinking, and if there's a point when he's drinking that he just feels he's got a bit more of a control of his anxiety, and that's that good that in inverted commas that good spot where he thinks, okay, I feel less anxious, but is he able to stop the drinking at that point, or does he just plow on and then feels a sense of shame afterwards and a loss of control, which might increase his sense of worthlessness that he started with? And then obviously there's all the risks afterwards about his with the burning of his skin and the cutting. There's obviously he's cutting in private places like stomach and thighs. He's not cutting on his forearms,
Mm,
which are visible.
mm,
So it feels like he carries a sense of shame around that act, to
mm.
me, as a guess.
And boys are quite tricky. I've always
Hmm.
found with self-harm, they're quite tricky. I think I feel a bit of relief now that I'm seeing more boys cutting. I don't know why, but I feel like it's becoming more okay to cut, whereas I used to see a lot of more severe, secretive forms of self-harm because of the image. Um,
So would you think this is for more permissive communication of distress, this earlier sign? Like I'm able to put it out there and I'm doing this self-harming and I'm seeking help rather than it being private, escalating, and then something catastrophic.
I've always thought so. I mean, when we used to, when all the research that used to say, well, women attempt more suicidal acts and men actually go through with more.
Yes, presumably because they're not able to feel permission to communicate it. It's not as socially acceptable. We hear about that so often, don't we, with male mental health,
Mm,
because it's not being, and the peer group discussion about it is not the same as with girls typically.
mm. And I think this is why I'm finding a bit of like, I know everybody thinks like, oh, social media is horrible with self-harm, but I think there is part of it that is letting kids tell us things
Hmm.
like this. And it's a bit of a nuanced area. It's a bit of a, I don't know, but I think assessing boys is completely different to assessing girls in my experience. I don't know what people think, but it's completely different. Um, but let's move on to the next thing, which is our menu of things. Now, in the end, I'm going to send everyone here. Just make sure that I've got your emails. If you haven't registered on the website, if you can pop your email on the chat, then I'll email you our little cheat sheet. And it has a little menu of things. But I thought I'll pick some things here so that I can bring your attention to your attention to management things to use. Now, traffic light system. Is everybody aware of what traffic light system is if someone isn't, can you please just put your hand up or put it in the chat so we can have a little chat about it? Okay, so I'm going to assume that people know what this is. Now, traffic light system. Oh, hi, Dina. So traffic light system is like, green, amber, and red. So you try and stratify where the person is feels. Are they feeling in the green? Are they feeling in the amber or the yellow, like a traffic light, or in the red? And you literally have a little like sheet, okay? And you put the three colors in, okay? And then this is obviously a small sheet. This is what I would do. I put like the three next to each other. And then we try and fill in what each one feels internally, and then what it looks like on my appearance. How can people guess? And then what would help me when this happens? And what would hurt me when this happens? And we try and populate this over time. So, and it helps you address all of the things in its simplest form. You literally tell the child, listen, This is when your risk is highest. It's red. And amber is when your risk is medium, when you're getting the thoughts, but you haven't acted on them. And green is when you feel okay. When you feel amber or red, you need to communicate with your ally. So you find an ally, and it's very similar to substance. Like I used to work with substance misuse a lot in the past. It's very similar. You have to find an ally, someone who's your friend, and someone that you can trust to tell. Usually, we try to find an ally in the family system who's a grown-up adult, who's a person who's responsible. And we pick a way to communicate. It could be a post-it on your door, and it could be a text emoji. And it could be anything, because children will not come to you and have a grown-up discussion about, oh, I want to self-harm because I feel depressed in this moment. It literally never happens. So you need a safe way to communicate, and people need to know what to do about it. So when you give me the amber sheet, what am I supposed to do? Am I supposed to make you a cup of tea? Am I supposed to take you to hospital? Am I supposed to talk to you about your feelings? You need to tell them beforehand. So traffic light system is one thing that I'm thinking about. Communication codes, again, this is what I mean when I say communication codes, is the simplest way of how you communicate. And then you've got the sensory box. And this is another thing that people might be familiar. If you're not familiar with what a sensory box is, then pop it in the chat or put your hand up. Again, a sensory box is one of the ways that you deal with things. So you try to, in the way that we do ABC, antecedent, behavior, and then consequence, you try to do preventative work. So how do you prevent? And part of the preventative work is allowing the person to communicate when they're struggling. Oh, I love this, the mood octopus.
Yeah, it's cool. You can one side of it is a smiley face, one has a sad face. You sort of can turn it inside out, and it's got different colours as well. You can choose, there's loads you can choose from, and he selected his favourite colours. And there's a happy colour with a smiley face and a sad colour with a sad face. And when he became situationally non-verbal, he could just present the octopus. He wouldn't give it to you, just be put at the end of the bed or the end of the desk, and I would know where he was at. And we had prearranged sort of what we could do for me to support him when he was in whichever state. It's just a really simple thing. I've seen quite a lot of neurodivergent kids
Oh,
use it.
it's not showing you, but this is it. Is this it?
Yeah, that's the
Yeah.
chap. Yeah, they're so simple. I love how angry and grumpy the sad one is as well.
I love this. I love this. I
Yeah.
absolutely love this. The mood octopus.
Yeah, and he was a late teenager. It wasn't like he was a little kid, but he really liked it, and we still use it today when things are difficult.
I'm gonna adopt this. Like literally, I'm gonna have
It's
one in the office and one else for myself.
go away, it's like go away, leave me alone, or I need help, or actually, I'm here to I'm part of the world today. Let's talk.
Oh, that's really helpful. That is really, really helpful. And I think it's really important then to find these little this is a very creative way to do things, actually. And it takes me to, and we're nearing our end now. Now it takes me to the next thing, which is medication. Now, once I've figured out how to close this, I'll show you what I meant. The last thing is medication. Now, hands up if you've been pressured before in high-risk situations to prescribe something. I just throw pills at it. It will make it better. And I often say this, look, I always say this, look, don't tell me to do an emergency medication review when a patient is high risk. This will only make things worse. If I prescribe something, it always makes things worse. Except sleep aids. Except sleep aids, in my experience. I don't know how people feel about sleep aids, like things like melatonin or something. And our colleagues who are joining from abroad will be, I think, flabbergasted when they know that melatonin is prescription only in this country, when you can buy it by the kilo abroad.
Even worse, in Wales, we don't actually prescribe it at all. I got told off once for
Really?
prescribing it.
Really?
Yeah, you really have to go through a checklist, and I have to speak with the clinical director, and it's a bit of a thing.
For
Unless I have,
melatonin?
yeah, unless I have
That's
a really good
bonkers. But
ration. unless I have a really
But
good
you can
rationale
get
for
promethazine over the counter, which
You
which
can
is
get
stupid,
them
right?
exactly.
it's really, really odd.
Exactly. It's always driven me nuts.
Yeah.
And promethazine is much worse.
Mm-hmm. Yep.
I think we're very
Nonsense.
far off from ketamine. I think it's gonna, if this is the kind of conversation that we're gonna have to be having for the next 5 years is about melatonin, ketamine is gonna take its good time to get to us. But melatonin, and I've done like I've has helped to reduce the risk in a lot of my young people. Even for momentarily, they do get mad at me, even though I explained to them very clearly in the beginning, it's a funny drug, because it's not a drug. It's a funny one. It will not always work. Sometimes it works better when it's a lower dose. Sometimes it works better when it's a higher dose. I have no idea. So I'm just gonna try. And often people will accept this, but antidepressants, I almost, unless I have a very good, I don't know how people feel, but unless I have a very good support system around the child, and I'm happy to start like in baby steps, I don't start antidepressants in the middle of a very high risk situation, because it tends to make things a lot worse before it gets better. It's not worth it. So this is my last thing, talking about our lovely Ed. And I've left some things on here. Probably have read these things, and this is where it inspired a little bit of this conversation as well, is the NICE guidance and the WHO guidance. And we've got lots of people who have joined. Oh, so Marwa's saying it's sold in supermarkets. Where are you, Marwa? Where is it sold? I didn't mean to call you out. I'm just wondering which country. So I know in America it's sold in supermarkets. In Egypt, it's sold like randomly if you find it. But oh, in Saudi, really? Interesting. I didn't know that, that they sold it in Saudi. Yes, absolutely. And they sell the gummy forms as well in Canada and America. They're quite good. They're quite good. So melatonin in the UK is still behind with prescription only. Somebody is making a lot of money from keeping this prescription only, is my theory. Like, but my husband always says to me, you always assume conspiracy when it's stupidity. It's just I believe in human intelligence. They cannot be this stupid. It must be a conspiracy. But I'm sure we'll catch up. I'm sure we'll catch up. I'm sure there's a very good reasoning behind it, and I'm sure we'll catch up with enough clinical consensus about these difficulties. I'm sure. I have hope. But in the meantime, people who have joined, I'm going to stop the recording, but people who have joined us a bit late, what we'll do is we'll share the recording if you'd like. And more importantly, we're going to share